On behalf of Amy and me and the other members of the collaborative of NAMI, Massachusetts, of the Department of Mental Health, of the Cancer Center, Beacon, and Mass Behavioral Health Partnership, we're really excited about the day yesterday. There were a lot of wonderful ideas generated, a lot of great energy and momentum, and today is really about continuing to move that forward. It's also about really recognizing the challenges of being a caregiver. And this is all of us. I mean, I have never been to a conference with all of these different places and people represented, over 50 different organizations, whether they be hospitals or health systems or universities. And I think it's a really nice opportunity for us to think together with people from different places in different disciplines, kind of think out of the box to generate creative solutions. These are some of the mental health agencies that are here. Some of the organizations they're advocating for things to improve. So we just wanted to talk briefly about who the caregivers are.
So caregivers, we want you to know that we see you and that we are working hard to think of ways to incorporate you into the cancer care system that we work within. When we did the pilot study, we really saw that caregivers for this population were a little bit different than the cancer caregivers that we're used to. So we were seeing spouses, family members, adult children, siblings, but we were also seeing community mental health workers as caregivers, not as employees, but as caregivers. Because many of the patients that we work with, their community mental health worker is their family. These are the people who see them day in and day out. They're visiting nurses, they're group home workers, they're community-based flexible support people, and they are invested in getting these patients through their cancer care, and we need to remember that they're part of the team. So we really have been working hard to think about how to meet the needs of a variety of caregivers, not just the family caregiver.
Absolutely. I think one of the key messages is that people have different kinds of families, and so we'll learn more about that. I also wanted just to invite Dr. Chabner to come up with me, just because I think one of the other unique things about this day is that this is really an interdisciplinary collaboration that really means a lot to the Cancer Center, and just to talk just very briefly about why this matters to the Cancer Center, this disparity, this unrecognized population. Thank you, Dr. Chabner.
Thanks, Kelly. Well, like a lot of things in the world of cancer and academic medicine, things wouldn't happen if it wasn't for an inspired person that takes an interest in some unmet need and really advocates for it, and not only brings intelligence, but brings passion to it. So I want to congratulate Kelly and all of you for feeling strongly about this and making it happen. It wouldn't have happened without her and without you. I'll just briefly tell you a bit about how this fits into the larger context of social interests of the MGH Cancer Center. I came here in 1995 from the National Cancer Institute, where I had largely been involved in cancer research, laboratory research, care of patients as part of clinical trials there, drug development, very heavy emphasis on molecular and biochemical pharmacology. Really, the aim was to develop drugs, and there was a whole system. There's a whole national system for doing clinical trials, which was part of it. But I'd always felt that one of the other missing pieces in this was that there were many people that were not reached in terms of the benefits of this research. Those that couldn't afford it, those that didn't know about it, those that lived in places where they had no access to it. And when I came to Mass General, I felt it was an opportunity to do both, to do the academic part of it and to improve the outreach and to touch the lives of people that didn't have an opportunity to take advantage of this. And it turns out that about 2/3 of the world's cancer patients don't have access to reasonable care. This is so obvious if you travel outside the United States to low and middle income countries, and we are involved in that as well through other programs. But here in the United States, there are communities of color, communities that are impoverished and that live, that are placed on a map far from facilities where they don't have easy access to care. So we have our own problems with this. I think it was not until Kelly came to me with her proposal to establish a program at NCI or at MGH for people with mental illness, serious mental illness, did I realize the extent of this problem. I had seen patients, obviously, who were mentally ill and had cancer, and I had some misgivings about whether it was possible to treat them and to carry through a program of chemotherapy, for example, which has its problems and toxicities and management issues. So was it safe? Was it possible to get compliance? All these things were really uncertain in my mind, and I think it took her foresight and energy to study this problem, to show that it actually could happen. So this is one of several of these kinds of outreach programs. It's the newest and the most exciting, but we've for the last 17, 18 years have had foundation support and NCI support and other sources of support for programs that reach out to immigrant communities, to communities of color, to do screening, to navigate to clinics, to try to understand the effects of poverty on accrual to clinical trials. A number of interesting things have grown up here that have not happened elsewhere in the cancer world. And this current problem is one of the most unique. So I've obviously been very interested and pleased to see it grow and to see the attraction of this idea for other cancer centers where it doesn't exist. So I congratulate you, Kelly, and all of you folks that are taking the day off to come here and listen and to maybe make it happen in your own institutions. Thanks.